to begin her presentation. Thank you so much for being here.
All right, thank you. So before I get started, I have a couple disclosures. I've served on advisory boards for the following companies, EMD Serono and Genentech. So today I'd like to talk about some of the updates in MS, and we'll kind of go over a broad overview of what multiple sclerosis is. Basically, we're going to talk about who is the typical MS patient. We'll talk about MS pathogenesis a little bit. We'll talk about the MS diagnosis and how we come to that. We'll talk about different types of multiple sclerosis and the typical disease course. And then we'll touch on some of the treatments that we have for multiple sclerosis out there. There are quite a few, and there were 2 new ones approved just this year. So we'll talk about those in some broad categories. And then we'll also touch on the treatment of relapses and the treatment of symptoms, which is quite a bit of what we do in the MS clinic as well. So who is the typical multiple sclerosis patient? So females tend to be affected more than males. We think it's about 3 to 1 female to male. Typically, with the relapsing remitting multiple sclerosis, which is the much more common type, we see patients between the age of 20 and 40 with a new onset of symptoms. Though certainly there are patients younger that have onset of their multiple sclerosis. And we also, I've diagnosed patients in their 60s and 70s as well, though typically they've had a relapse earlier in life that I've been able to figure out by taking their history. Caucasian people are more likely to develop multiple sclerosis compared to non-Caucasian patients. And then in general, patients who are atypical, so patients who don't meet these typical guidelines tend to have a more aggressive disease course. So that's when I start to think maybe their disease course might be more aggressive. If I had, for example, an African-American male in his 50s presenting with a new MS attack. So let's talk a little bit about MS pathogenesis. So in multiple sclerosis, these autoreactive lymphocytes cross the blood-brain barrier into the central nervous system, and this results in inflammation around the veins. This inflammation sets off a cascade that results in demyelination, so the myelin being broken down and destroyed, and then also injury to the underlying axons themselves. Over time, the neurons die and they actually form these black holes on T1 weighted sequences called T1 black holes. And initially we thought MS was really a white matter disease, but now that we have some better imaging, we're able to see that it affects both gray and white matter. So this first image over on the right side shows this lymphocytic infiltration. So lymphocytes, around the vein. And then over on the other side, there's an MRI image showing these T1 black holes, which can be helpful in making the diagnosis. So initially, we really thought that MS was a T-cell driven disease, specifically a shift to the Th1 pathway. But we now know that B cells play a role as well. Interestingly, some of the early MS drugs like letermovir acetate, brand name Copaxone, partially works, we think, by causing a shift from the Th1 to Th2. What we know about B cells is we know that in patients who have progressive MS, they actually have these lymphoid follicle-like aggregates that form in the meninges of the brain. So we think that some of the progression may be B cell driven, and this is why drugs like ocrelizumab or Ocrevus or rituximab or Rituxan may be better for progressive disease. So in terms of risk factors for multiple sclerosis, there's some pretty well-defined genetic risk factors out there. We know that the HLA DRB1 1501 phenotype is associated with a 3 times greater odds of developing multiple sclerosis. And then we know patients that have the HLA marker HLA-02 have a reduced risk of developing multiple sclerosis. Though we don't usually use, genetics to guide our diagnosis and prognosis at this time. In terms of environmental risk factors, On here are some of the more well-known ones like Epstein-Barr virus. So we know patients who have been exposed to the Epstein-Barr virus or had infectious mononucleosis are at increased risk for developing multiple sclerosis. And things like vitamin D deficiency and low sunlight and exposure have been well defined as well. We also know that adolescent obesity may increase the risk of a person getting multiple sclerosis, smoking. And then one that I thought was interesting is shift work, because I have quite a few people in the healthcare profession who have been diagnosed with MS who work at night. We think that that may be due to some melatonin dysregulation that happens. It appears that to some degree, perhaps coffee and alcohol consumption may decrease the risk, so that's good news. And there's some information that a high salt diet may worsen multiple sclerosis. And then, like I said, hopefully high coffee consumption is protective. That would be helpful for many of my patients and myself as well. And then shift work may increase the risk. So let's move on and talk a little bit about how I make the diagnosis of multiple sclerosis. So when I'm diagnosing multiple sclerosis, I look at 5 key principles. The first principle is they have to have some kind of neurological syndrome that looks like multiple sclerosis or that localizes to the central nervous system. Okay, and we'll talk about what that looks like coming up. The second is we have to see objective evidence of central nervous system involvement. Usually in this day and age, that's lesions on the MRI, but it could be other things as well. Like I could see an afferent pupillary defect. You can do evoked potentials and things like that if a patient can't get MRIs or if you don't see MRI evidence. You have to have dissemination in space. So you have to have lesions or evidence of dysfunction in multiple areas. You have to have dissemination in time. And very importantly, no better explanation than MS. So you have to rule out all the mimics. One of the typical MS syndromes I typically see in my patients is optic neuritis. And in MS patients, it tends not to be very severe optic neuritis. What patients tell me is that they have, they're looking through fog or looking through a dirty window, or that in the center of their vision, it's blurry or grayed out, or everything looks muted. They typically have pain with eye movement. If you do a fundoscopic exam in the acute phase, you'll see swelling of the optic disc. And then later on, you'll see temporal pallor. So you'll see a pale optic disc typically in the temporal location. And MS patients often have a good recovery of visual acuity. They usually tell me my vision got 80% better. And if they don't have a good recovery of their vision, that's kind of a red flag that something else might be going on. This is kind of an image of what I imagine optic neuritis to look like on the right side over there, the blurry one. And then we also have color desaturation, especially to red. Sometimes they tell me it looks pink or brown. Other typical MS syndromes that I see, you can see brainstem syndrome. So if you look at a patient, you could see an INO or eye movement abnormalities, cerebellar syndrome, so ataxia. And then a typical myelitis-like syndrome, not even necessarily transverse myelitis, but things like sensory changes in the arms and legs, especially if they're kind of ascending into the abdomen or chest, weakness, and then bowel and bladder involvement as well. We're going to skip that one. So the next step is looking for objective evidence of CNS involvement. So for example, if a patient had a history of optic neuritis, I could find an afferent pupillary defect doing the swinging flashlight test. In a patient with double vision, I could find intranuclear ophthalmoplegia. And then, I actually don't see a lot of hemisensory levels with multiple sclerosis, but if you found one, that would certainly be very helpful in pointing to a spinal cord pathology. And then another example is looking at MRIs. I could see a hyperintensity or enhancement on MRI of the orbits. Or I could see a hyperintense lesion on MRI of the spine. This might be a little bit out of the scope for this lecture, but this just goes to show that there are actually a lot of things that can cause myelitis or inflammation of the spinal cord. Things like, neuromyelitis optica, which is an MS mimic, polio, which hopefully we won't see much anymore if people get vaccinated for that. Vitamin B12 deficiency, ischemia is one that can be tricky as well. And then herpes can also affect the spinal cord. But those top three images are really what I typically see when I look at the MRI of a patient who has multiple sclerosis. And the other ones might be kind of a red flag. The next one is dissemination in space. So the MRI has to show lesions in at least two of the following areas. So they have to be periventricular, cortical or juxtacortical, if infratentorial, so in the brainstem and or cerebellum, and in the spinal cord. And these images down here just kind of show some different areas that tend to be affected. So this image showing the brain down on the left side, down here, not sure if you guys can see my arrow, shows some periventricular lesions or Dawson's fingers, which are very typical for MS. Next to it shows some images of lesions in the brainstem and in the cerebellum. And then over on the other side, you can see this very typical juxtacortical lesion. And that's really important because oftentimes patients have some ischemic findings in their brain, some evidence of chronic small vessel ischemia, or they have a history of migraine and they can have some white matter lesions. And one of my main jobs is to look at the MRIs and decide whether it looks like multiple sclerosis or not. In terms of dissemination in time, traditionally we thought of this as being two separate attacks or two separate relapses. But we've made it easier to diagnose multiple sclerosis now that we have very effective treatments. So we've done things like have if they have both enhancing and non-enhancing lesions, that's some evidence of dissemination in time because one is active and one is inactive. And then most recently in the 2017 McDonald criteria, we've allowed two unpaired oligoclonal bands in the cerebrospinal fluid to substitute for dissemination in time. All right, so if a patient had one clinical attack and lesions that look like multiple sclerosis in multiple areas, if they have unpaired oligoclonal bands in the cerebrospinal fluid, we say that's enough. You can be diagnosed with multiple sclerosis at this time. And the last one is no better explanation than MS. So these are just some of the things I think about when I'm looking at MS patients. So some of the other demyelinating disease like neuromyelitis optica and a new one called MOGAD or MOG antibody disease. Sarcoidosis can affect the central nervous system in about 5 to 10%. Infections like Lyme disease and tuberculosis can be tricky. CNS vasculitis, a CNS lymphoma can sometimes look like MS and then very confusingly respond to steroids. And then paraneoplastic syndrome, so in older patients who have a history of small cell lung carcinoma, for example. Some red flags that I see. So patients who have really severe optic neuritis or a poor recovery of optic neuritis, I worry about other things, other demyelinating diseases, then also like ischemic and non-ischemic optic neuropathy. I think about those as well. Patients who've had multiple cranial nerve involvement, so like an optic neuritis and a history of Bell's palsy, or a cranial nerve 7 involvement, that would make me worry about these. And then also involvement of the nerve roots makes me think about sarcoidosis or perhaps Lyme disease. And then patients with systemic symptoms like joint pain, skin changes and rashes, unexplained weight loss make me worried about systemic autoimmune diseases and things like cancer. These are some images of some of the mimics. The one on the left is a picture of a spinal cord with something called longitudinally extensive transverse myelitis, so inflammation that's extending more than 3 levels. And that's kind of a red flag for MS mimics. And then optic neuritis that affects a longer portion of the optic nerve and the optic chiasm is sort of a red flag as well. Let's talk a little bit about different types of multiple sclerosis. So there are 2 main types of multiple sclerosis, relapsing MS and progressive MS. And this is really defined based on the initial course. So with relapsing MS, patients have some sort of neurological dysfunction that's usually one of those syndromes that lasts for more than 24 to 48 hours. And then typically they'll have some improvement or at least stability in between their relapses. Patients who have primary progressive MS have typically a gradually worsening gait. They typically have a picture that looks like myelitis. So they'll have gradually worsening ability to walk, weakness in the legs, numbness, and bowel and bladder changes. And that usually happens over years. And before they've gotten to me, they've had a big orthopedic workup and workup for more common diseases. So here's an image kind of showing what relapsing remitting multiple sclerosis looks like. Relapsing remitting multiple sclerosis precedes secondary progressive MS. So it starts off kind of, if we look at this graph over here, you start off with having maybe some MRI activity, so some lesions forming in the brain, and then a relapse, and then a period of stability. Maybe the person recovered all the way and has gone back down to their baseline level of disability. They can accumulate some disability over time from relapses, but in between those relapses, they shouldn't be having a gradual worsening of their symptoms. All right. In secondary progressive MS, patients have an initial relapsing course, so they'll have no change in their disability in between relapses, but then over time, they'll start to develop some progression that's independent of relapses. So they'll start to have worsening disability or new neurological symptoms that become worse in between their relapses. Which is the definition of progression. And they can continue to have MRI activity that's independent of that as well. In primary progressive MS, they typically start off having some gradual progression. They can have periods where they don't have any progression. So they can have periods of time where they're not getting worse. And then later in their disease course, they can have things like MRI activity. These little purple arrows are MRI activity, and they can actually have relapses later in their disease course, which can be very confusing for people who aren't used to seeing a lot of patients with primary progressive MS. Now I'd like to move on and talk a little bit about multiple sclerosis treatments. So in terms of treating relapses, first line, I usually use IV methylprednisolone or IV solumedrol, and I typically use 1 gram daily for 3 to 5 days. There's been some evidence that oral prednisone is not inferior to IV solumedrol to treat relapses, which is great because some of my patients have horrible venous access or difficulty getting to the infusion center, or maybe their relapse isn't too bad and they're able to keep working and they don't want to take time off of work to go to the infusion center. This has also been nice for some of my patients who are older who are immunosuppressed during the COVID-19 pandemic. As long as they can swallow, usually they can take oral prednisone. The only problem with treating them with oral prednisone is that you actually have to take 25 tablets of the prednisone 50 to get a kind of a bioequivalent dose to methylprednisolone or solumedrol 1 gram. And it's kind of gross, but my patients tell me that if you take it with chocolate milk or chocolate syrup, it masks the taste. And I usually have them take it all at once in the morning to avoid insomnia as much as possible. All right, and then I usually reassess them in 2 to 3 weeks or in a month after a relapse to see how they did. Some of my patients can't tolerate steroids or they have uncontrolled diabetes. And in that case, you can try ACTH or Acthar. The only issue is that's very expensive and can be hard to get. If you can't get Acthar, or if a patient has a really severe relapse or incomplete recovery, you can try plasmapheresis or plasma exchange. The only issue with that is you have to have a dialysis catheter. I've done this before previously at other places, outpatient. Here I've done it inpatient, so you have to actually admit the patient for about 10 days to get this done. In IVIG, there isn't sufficient treatment, though. We do sometimes use it during the first trimester of pregnancy, for example. This is just kind of a figure that shows kind of how we're going along doing the treatment of a relapse. Now we're going to talk a little bit about the disease-modifying therapies, and I'm going to lay it out just like I do for my patients when I'm telling them about all the different disease-modifying therapies, because there are a lot of them out there. And I wouldn't expect you guys to have to prescribe them. The oldest medications that we have are the injections. or the shots. And these include the interferons like beta seron, which was the first one, and then Rebif, Avonex, Extavia, and Plegridy are some of the other ones that we use. These medications tend to be fairly safe, but many patients develop flu-like symptoms, and shots can just be really difficult to tolerate in general. Another shot that we have is glatiramer acetate or Copaxone. And this I think of as my safest drug to treat multiple sclerosis. It can be either given daily or 3 times a week. Patients tend to prefer 3 times a week. And this medication I feel is fairly safe in pregnancy and when at attempts at conception. So that's a time that I use glatiramer acetate fairly frequently, and also in patients who I'm concerned about side effects from other medications or safety issues. So for example, a patient who's on dialysis or has cancer and is undergoing treatment for cancer with chemotherapy, I wouldn't expect this medication to interfere with any of those things. So this would be a good choice. Ofatumumab, or Kesimpta, is actually our newest medication that's approved for multiple sclerosis. And this is actually very different from the other shots. And I've been kind of lumping it in with ocrelizumab or Ocrevus because it works in the same way. It works by depleting adult B cells. So the only real difference between it and ocrelizumab is that it's an injection that a patient gives himself once a month rather than getting an IV therapy every 6 months. Okay, and this has been beneficial for some of my patients who live far away from infusion centers and or don't want to have to take off work to go to the infusion center. There's also some evidence that the B cells may come back a little bit faster with ofatumumab, maybe around 9 months, whereas with ocrelizumab, the B cells take quite a long time to come back. So ofatumumab might be better for somebody who you're worried about getting recurrent infections, because that's one of the issues with our B cell therapies. There are quite a few pills, as you can see, out there. We've had a couple new ones approved just in the last few years. And I won't go through all of them. Teriflunomide or Aubagio, dimethyl fumarate, and diroximel fumarate are some of the medications that are a little bit less effective, but tend to be a little bit safer in terms of infection risks. The S1P receptor inhibitors or modulators, which include fingolimod, siponimod, and ozanimod down here, those medications all work kind of in the same way. They work in a very clever way by trapping the lymphocytes inside of the lymph nodes, all right? And those have some infection risks with them, but especially siponimod or Mayzent may have some benefit in secondary progressive MS. It's slowing down progression, okay? And then Mavenclad or cladribine is an immune reconstitution therapy. So it's an oral medication that you take. You do 1 course and then you do it a month later, and then you repeat the whole thing a year later. And what it does is deplete certain cells in the immune system and then allow them to reconstitute over time. And the idea is that the immune system is friendlier and that different subsets of lymphocytes grow back and that you're less likely to have relapses for a period of time afterwards. The IV medications, to be honest, are the ones that I use the most frequently in many of my newly diagnosed patients. And these include Tysabri or natalizumab and Ocrevus or ocrelizumab. Those medications are highly effective. Natalizumab or Tysabri is the medication that's associated with a higher PML risk. So I watch the JC virus antibodies really carefully in patients who get that. It's an IV you get once a month. Ocrelizumab or Ocrevus is an IV therapy you get every 6 months, and it's very similar to Rituxan or rituximab and to ofatumumab or Kesimpta. And alemtuzumab or Lemtrada is a medication that's an immune reconstitution therapy like cladribine, except it's an IV therapy, and it's really a chemotherapy that they get in an infusion center that you do once for 5 days, and then at 1 year you repeat it for 3 days in a row. And the benefit of doing that medication is years later, many patients don't have relapses and they don't have any further disease activity, and you may not have to treat them again. And it's also a very effective medication for people with aggressive multiple sclerosis. And I kind of color coded these. So the red ones are ones I think of as being high efficacy medications. And these are the ones I tend to use in patients who are younger and just getting diagnosed, who I'd really like to treat high efficacy initially, because our evidence now, it looks like perhaps the old escalation model isn't the way to go, and that treating with high efficacy early on may reduce the risk of having severe disability later, and it may even prolong that initial relapsing remitting phase and delay the onset of progression. And many of my younger patients are the ones, if I had to treat somebody with medications that may increase the risk of infections, I'd rather do it in a younger patient and not wait till a patient is older. The purple ones are kind of the mid-range medications that I use sometimes. And then the black ones are medications that are a little bit lower efficacy. And other MS doctors certainly have different ways of doing things. I tend to be kind of an aggressive treater of multiple sclerosis, especially early in the disease course, which is sort of the trend that ways things are going these days in the MS community. So let's talk about the goals of these disease-modifying therapies. The goal is something called NEDA, and NEDA stands for no evidence of disease activity. What no evidence of disease activity means is that nothing new is happening. And this is really a difficult concept for patients sometimes, and sometimes they forget that this is the purpose of the disease-modifying therapies. And they'll tell me that their disease-modifying therapy isn't working. They'll say, I take ocrelizumab and I feel horrible still. I felt bad before I started it. I feel bad now. It's not working. And I have to remind them, no, we can treat your symptoms, but the purpose is NEDA. All right, what NEDA means is no relapses or attacks, no new or enhancing lesions on the MRI, no worsening of disability. So I don't want my patient to come in and walk well, and I don't want to see them in 5 years and be walking with a cane. And no accelerated brain atrophy. So we know that patients who have multiple sclerosis have accelerated brain atrophy, especially in the center of the brain, compared to healthy controls. So I would like my disease-modifying therapy to slow that down. And some of our disease-modifying therapies are a little bit better at that than others. Some tips and tricks for prescribing these disease-modifying therapies. Drugs that are fairly safe in pregnancy, so glatiramer acetate, that's one that I typically use in women who are actively trying to get pregnant. Drugs that may increase the risk of infections, both run-of-the-mill infections like urinary tract infections and upper respiratory infections, unfortunately, like COVID-19. And skin infections like cellulitis and herpes infections are ones I see pretty frequently in these drugs. The S1P receptor modulators, so the MODs, and then the B-cell therapies, so ocrelizumab and ofatumumab, as well as rituximab, which I didn't include on here because it's off-label for MS, but we still use it sometimes, a little bit less expensive than ocrelizumab. Drugs that may lower circulating lymphocytes. So the S1P receptor modulators, that's how they work. They work by trapping the lymphocytes inside of the lymph nodes. All right. So they do that for the duration of treatment. So patients should have a lower level of, they should have a little bit of lymphopenia during the whole duration of treatment. And then the immune reconstitution therapies like alemtuzumab and cladribine temporarily decrease the lymphocytes counts. What about the treatment of symptoms? So symptoms are something that I treat quite a bit. And it's separate from the disease-modifying therapy. So when I was training to be a neurologist in my residency, a lot of neurologists told me that MS patients don't have pain, or that pain isn't a part of multiple sclerosis. And that's not true. A lot of my patients have neuropathic type pain, burning, tingling, stabbing pain. A lot of them have unpleasant sensations, like they'll tell me that there's a rolled up, it feels like they're stepping on a rolled up sock, or that there's something underneath their feet when they're walking. Bowel and bladder dysfunction and sexual dysfunction are really big, especially in primary progressive MS and in patients who have spinal cord disease. So that's something that I treat quite a bit. Spasticity, a number of my patients have very bad spasticity. In terms of oral medications, I like baclofen as an initial oral medication. And then people who have more focused spasticity, like perhaps they just have spasticity in one of their hands or in one of their legs, toxin injections like Botox and Dysport are great. And then patients who have severe spasticity that either can't tolerate or baclofen or toxin injections, or they're just not working, can really benefit from intrathecal baclofen therapy or ITB or baclofen pumps. Mood is a huge problem for a number of patients, not just MS patients, but that's something that I treat quite a bit. And then fatigue. Fatigue can be really disabling as well for many of my patients. And they can both have excessive daytime sleepiness as well as motor fatigue. The motor fatigue can be very severe, and they can, run out of steam midway through their day and have to take rests. They can also have severe heat sensitivity, and they can have something called Uthoff's phenomenon, where actually exposure to heat can make their symptoms worse, their old symptoms. So I have patients, for example, I had a patient who was a high school student who played football, and he had a very bad brainstem relapse. And he had a great recovery, except when he played football, he would get double vision and become dizzy and nauseated, and he wasn't able to play. And then cognitive dysfunction can be a big problem, especially later in the disease course, which is one of the reasons I like to use the effective medications early on, because things like cognitive dysfunction are extremely hard to treat. So one thing my MS patients tell me is they ones who don't have a lot of obvious physical disability will hear, "But you look so good." And the fact is, MS is kind of like an iceberg. So what we see is the top of the iceberg, and we see mobility issues, and then we see a few other things, like perhaps they can't use their hands appropriately, or they're unable to see, or they could have some eye movement abnormalities. They're obvious to other people. But when you look below the iceberg, they have a lot of other symptoms that can also be really disabling and terrible for them, including neuropathic pain, bowel and bladder issues, severe fatigue, depression, anxiety, and cognitive dysfunction can all be very bad and can actually take the patients out of the workforce as well. And treating these symptoms and paying attention to these symptoms, especially things like mood, fatigue, and cognitive dysfunction, are really, really important. And I try to talk to my patients about that as much as I can, and try to treat those symptoms. So in conclusion, today we talked about what a typical MS patient looks like and some of the atypical features. We talked about MS pathogenesis and the risk factors associated with multiple sclerosis. We talked about how we make the multiple sclerosis diagnosis. We talked a little bit about the MS disease course and different types of multiple sclerosis, so relapsing MS versus progressive MS. We talked about some of the MS treatments, and we talked about the treatment of relapses, so with steroids or with other things like, ACTH or plasmapheresis. We talked a little bit about the disease-modifying therapies and all of the different types, the shots, pills, and the infusions or IV therapies. And then we talked a little bit about the treatment of symptoms. Here's my work cited, and then I think we probably have some time for questions.